is based on the ATTC network model. The ATTC network has been around for about 25 years. The Great Lakes Mental Health Technology Center has been around just about a year. There are multiple regions. We are Region 5, but these are the regions all over the United States and the Caribbean. And this is a close-up of our Region 5. So the housekeeping, our webinar format today will be recorded and available for viewing along with the PowerPoint slides on our mental health website. That should probably take a couple of weeks. So go ahead and look back. Today's audio will be broadcasted through your computer speakers, so make sure that your speakers are turned on and up. We don't have a call-in number available. You can use the chat box feature throughout the webinar to ask questions or add comments. We will do some answering questions during the presentation, but we will, provided we have time, have a Q&A session at the end of the presentation. Our speaker today is Elizabeth Koshman. Elizabeth is a faculty member of the Department of Psychiatry and the Director of TRAILS, a program that works to disseminate evidence-based mental health practices to K-12 schools. Elizabeth's research is focused on identification of ways to improve community access to effective mental health care, particularly by training school professionals in best practices. Elizabeth's area of clinical expertise is in the treatment of depression, anxiety, and PTSD in children and adolescents using the cognitive behavioral therapy and mindfulness practices. She has worked extensively as a trainer and consultant for a variety of academic and community-based audiences, including providers working primarily with youth in foster care, and is a lead investigator in a number of state and federal research grants evaluating mental health and implementation models. Welcome, Elizabeth, and thank you for joining us today. I'm going to turn it over to you.
Thanks for having me. So I'm going to get started. I will say that we do a lot of presentations and talks, and I'm much more used to having a very dynamic, interactive presentation style than just being a speaker and not being able to see or talk to my audience. So I see that there's a chat function here. Please feel free to type in your questions as you're participating, and I will actually pause and try to respond to questions as they come up, because that will help me feel more like we're having a conversation and less like I'm talking at you. So thank you for having us present here today. I'm joined in my room with two colleagues that support our work across the state of Michigan, and I'm really excited to be able to share with you a little bit about the TRAILS program. TRAILS, just as an overarching mission, aims to improve access to evidence-based mental health practices, specifically using the school setting as a vehicle to try to reach kids who otherwise would not make it to an evidence-based treatment due to so many barriers that young people experience. And we really focus on how to provide training and implementation support to schools and staff in buildings to be able to deliver those evidence-based practices independently and sustainably. So that's just a very brief introduction, and I'll obviously go into a lot more detail as we move along. One of the reasons, I don't think I need to explain to this audience, but one of the reasons that we're motivated to do this work comes through our partnership with Michigan Medicaid here locally, and our effort to try to reach students who are in high Medicaid enrollment communities in particular. We do have a statewide footprint, and certainly we're in communities that have more resources and higher income populations, but we are really motivated by trying to improve access to evidence-based practice, specifically among kids that traditionally experience a high number of barriers to care. And these are obviously kids who are exposed to a high number of ACEs and without access to care are at elevated risk for a number of poorer life outcomes. In particular, we think a lot about the population health impact of untreated mental illness. And you can see from that chart, again, I assume this is a very knowledgeable audience that I'm speaking to, so I won't spend too much time on this context, but that we recognize suicide and homicide as the two leading causes of death behind unintentional injury, and both of those we think of as closely related to the presence of mental health or mental illness without access to treatment. And actually, I would argue that that unintentional injury category also includes a lot of kids who are impacted by mental illness just due to the relationship between injury and engagement in high-risk behaviors, difficulty with impulse control, poor decision-making ability. And so we really think about the potential for evidence-based practices to have a significant reduction on early mortality and morbidity at a population level, and then of course within our individual communities and families that we partner with. There's a lot of talk about evidence-based mental health practice, and I am sure specifically within this group. And we actually struggle a little bit with the concept of evidence-based practice because the term has become quite watered down over the past decade or so. And what counts as an evidence-based practice starts to blur a little bit as we reach out into community settings. And also due to some other weaknesses of evidence-based driven care, being that sometimes the evidence base for a certain practice really doesn't align with the real-world clinical populations that need treatment. So for example, if we look at the evidence base for treatments for pediatric anxiety, we might discover that a lot of the most rigorous trials have been conducted with young people who are screened before they're entered into the trial to rule out comorbidities, exposure to trauma, significant environmental stressors, et cetera. And that when we look at the population of kids that are accessing services in our schools as their primary care setting, these are kids who are dealing with incredibly complicated family contexts, environmental community settings. And so we are also trying to shift away from just looking at a traditional definition of an evidence-based mental health practice. And the TRAILS model really aligns with the research on common elements of evidence-based practices. So work by colleagues at UCLA and Harvard and at other academic centers across the country have started to point to the advantages of looking at the components of evidence-based models, so published protocols, and distilling those treatments down into their core elements. And when we do that, we really see that across protocols that have strong evidence for treating kids with depression, anxiety, conduct difficulties, substance abuse, post-traumatic stress disorder, they are all really grounded in a strong cognitive behavioral therapy framework and more recently integrating mindfulness as an approach to help kids cope with and navigate adversity and personal symptoms of mental illness. So when we think about what we want to disseminate to communities to improve access to EBPs, rather than try to present a protocol or a particular manual, we really try to educate our community partners in these two theoretical frameworks of CBT and mindfulness and provide training and education and clinical tools to support their development of competency in a host of core clinical skills rather than a session-by-session manual that has to be adhered to with a lot of rigidity. So we look at CBT and mindfulness in particular. Additional advantages of those two approaches for the school setting, of course, is that they're very skills-based models. They don't require an incredibly high degree of clinical training in understanding etiology of mental illness or delving into personal narrative, but they really allow even a novice clinician or somebody who has a less clinical role to be able to focus on teaching strength and solution-focused coping skills and strategies. So our school partners, particularly administrators, superintendents, and principals who are hesitant to have their school staff providing therapy in the school setting, they're much more comfortable with this model because they can think of it as a skills class or a skills lesson that a school professional is really utilizing appropriately for their setting. Of course, there's also pretty strong evidence in the literature that CBT has good associations with improvements in outcomes that are relevant to schools. So, of course, health, but also social, academic, personal, and functional outcomes related to goal setting, perseverance, and reductions in impulsivity. So really appropriate models for the school setting. One of the other weaknesses that TRAILS aims to ameliorate through our programming has to do with reach. And this is a concept related to the idea that evidence-based practices can be terrifically beneficial, but only for the kids who are able to access them. And if you have a really highly efficacious model, but it's really hard to get that model to the people who could benefit from it, then the overall value of the model is drastically reduced. So we are also thinking about the advantage of CBT and mindfulness in that they both models have the potential for extensive reach. That if we can get the training into the hands of people who are interacting on a regular basis with kids in schools, then much higher numbers of kids will be able to access the models and benefit from them. So we also like to talk about reach. Another relevant point to make about reach is that we don't want to think about delivering to schools necessarily the most perfect version of CBT and mindfulness. So certainly there are sort of higher end CBT models that have been evaluated in clinical trials that are extensive. Trauma-focused CBT is a really good example. Requires pretty significant training and practice. And yet, if we require schools to deliver that absolutely perfect model, then again, we're going to start to reduce the reach of the model. So what we want to offer to schools is not only something that's effective, but something that feels feasible for our school partners to deliver, something that is straightforward, concrete, can be distilled into a small number of treatment components. So we sort of have to balance our efforts to push out into the community something that's efficacious with something that our school partners are actually going to go on and deliver, rather than look at and feel confused by or feel too burdened from. So we try to balance those two goals. I think this group is already aware, if you're joining the call, obviously school mental health is an area of interest to you. But there is really emerging evidence and a strong political push towards integrating mental health with schools. We, of course, see a high number of kids who fail to engage in outpatient treatment or who engage but don't persist in outpatient mental health treatment. Certainly we see many, many kids that experience barriers to care in the community. And therefore, the school is quickly emerging as an ideal setting for providing services to those students so that kids who experience transportation barriers, health insurance barriers, of course, stigma, lack of an involved parent, and other factors that really mitigate their likelihood to engage in clinically based treatment are going to be more likely to access services in our school setting. So that's really behind the model of TRAILS and why it is that we are so encouraged to partner with schools in trying to reach high numbers of kids. One of the concerns about working with schools has to do with the preparation that the staff on the ground in those settings have when they come into the workforce. So the partners that we typically think about working with are school counselors, school social workers, school psychologists, sometimes nurses, although of course nurses are being reduced in numbers, I think, across the country. Certainly here in Michigan, we're seeing those positions eliminated rapidly. But generally, our core model at Trails is focused on working with these student support staff professionals who are in positions where they interact with kids experiencing mental illness and related symptoms on a regular basis. So typically, we have not worked as closely with school teachers because their role, while they certainly play an important role, and I'm talking in a moment about our work with the classroom setting, but typically teachers are not in a position to be able to provide mental health counseling or support services either one-to-one or in a group format, whereas these other school professionals, whether it's in their stated job description or not, they're absolutely providing those services. And in all of our survey research, we are finding that school counselors and social workers across the board are saying that on a consistent and regular basis, they're providing both individual and group therapy or counseling to students. And you can see on that slide that the variety of challenges and concerns that kids are bringing into the school setting are extremely significant. We know that our school partners are very concerned about suicide in particular. Here locally, our district experienced one of the worst years that we've experienced. Just a couple of years ago, we lost 16 students across our county to suicide, and that has really prompted our community locally and across the state in Michigan to think about what kind of training and support do these school staff need to be able to provide services to students that are going to be beneficial given this high severity and high rate of concerns that they're coming in the doors with. When we have surveyed our school partners about the kinds of training and preparation that they get in their graduate programs and through professional development, what we learn is that their job descriptions do not position them to be those providers of therapy. And certainly social workers in particular are best positioned in the school to offer those services, but often their role is really limited to providing special education services, assessment, and sort of referral and resource connection supports to students. And so they tend to be providing services to kids that fall far beyond what their training has prepared them to do. In a traditional model of training and professional development for staff, what we're supposed to see, of course, is graduate school that prepares staff adequately for the actual roles that they will play in their buildings, followed by professional development offered through the school district throughout the year, and ideally that would lead to delivery of best practices. What we hear from our partners is that that is just really not possible, that these individuals are in their schools, and as I mentioned, they may have limited professional training through their graduate programs in these evidence-based practices, but what's more salient to us is that professional development is sometimes offered. As I said, there's clearly growing momentum to utilize these staff and personnel in a supportive role to kids impacted by mental illness. So professional development is frequently offered. However, typically this professional development is formatted as a one-day or even a one-hour workshop or seminar, maybe with a binder of materials to take home, possibly with an online resource that staff can access. But we know both from practice and from the literature that a one-time professional development is really not at all impactful for changing clinical behavior or even changing clinical expertise and knowledge in a long term. That these staff get back to their buildings and they have caseloads of 200 to 600 kids. They have a line of kids out the door. They have parents contacting them, and many of them are being utilized in a variety of roles throughout their buildings, including lunch supervisor and bus duty and crisis response team and a lot of other administrative roles, and they just don't have the opportunity to go back and reference training materials, slides, binders, follow up with online additional training options, etc. And so what you see is an initial increase in knowledge or competency, or even an increase in intention to use a new clinical model, followed by a pretty rapid return to baseline of all of those knowledge, expertise, and even intention to use a new model, because it's just not possible. However, implementation strategies are gaining a lot of traction as skills that can be applied post-training, so following that professional development, to increase the likelihood that a trainee will utilize a new clinical skill, and also increase the quality of that clinical skill. So adherence to a way in which it was trained, adherence to a protocol or a manual or another resource. So TRAILS is really built to be a model that is an implementation model. And as an implementation model, we have 3 pillars. So that includes a one-day training in core elements, as I said, those common elements of CBT, along with a variety of printed resources and materials. And we really consider this training to be the starting point for our relationship with our school partners, rather than the culmination of that relationship. Following the training, TRAILS offers web-based support, so we have electronic resources hosted. They're currently public domain, open access on our website, which I'll talk about in a moment. It's trails2wellness.org. But those electronic resources come in a variety of formats. We have them organized by session-to-session agendas, as well as individual treatment component resource materials. And those are all built to be appropriate for the school setting, to require minimal preparation or additional resources on the part of the school professional, and to be really easy to access and to navigate within our website. And then what makes TRAILS most unique is this third pillar, which is that following the training, we pair every school professional with a trained TRAILS coach who is local to their own community. And the coach joins the school professional for co-delivery of a student skills group for 1 semester. And during that skills group, the school professional is responsible for leading the groups, while the coach is really there to provide post-training implementation support. I'm going to come back to the role of the coach in a moment, but I want to talk for a minute about who these coaches are. So the coaches tend to be community mental health providers, master's level clinicians. In the case of the state of Michigan, they're pulled from almost every county in Michigan. And we provide a similar one-day training. In fact, we hosted a training yesterday for community mental health providers across Wayne County, which is where Detroit is located, for those of you not familiar with Wayne County. We provided a one-day training in the same core elements of CBT and mindfulness. We offer them their own coach section of our website, which has both clinical materials as well as sort of a higher level material specifically for somebody who's going to play the role of a coach. And then following the training for coaches, we provide one-to-one consultation for about 15 weeks. Each coach is paired with a TRAILS staff member who maintains a caseload, or I shouldn't say caseload, but a cohort of coaches in training, or CITs. And those coaches are required, before they can become an official coach, to deliver a full TRAILS curriculum to a client from their active caseload. I'm going to go into more detail about what consultation looks like, but it's a pretty intensive 15-week process that entails practice and live observation of sessions, and a lot of back and forth communication between the coach and the consultant, or the coach in training and consultant. Following that consultation phase, the consultant and the CIT work together to complete some self-evaluation materials and consultant evaluation of the CIT materials. And then by invitation only, we invite a subset of those CITs to attend an additional one-day training, which is not focused on the clinical content anymore, but is really focused on our coaching protocol. And we provide a very comprehensive coaching manual that walks each coach through exactly how to partner with a school professional. So if I go back a slide, you can see this is the training that is offered for our school professionals, training, web support, and coaching. And this is the training that's involved for our coaches, training and web-based support, but then one-to-one consultation for that 15-week period, and an additional training specifically on our coaching protocol. Here's another graphic. This is actually a graphic that we built for that initiative that I just mentioned, working with Wayne County. And you can see sort of the time it takes that we provide that initial training for CITs. As I said, we did that just yesterday with about 80 community mental health providers from all over Wayne County. Now we're just beginning the consultation phase of our work with them. Starting this fall, we'll begin to communicate with all of the schools that those coaches will be partnering with to help them start to prepare for the upcoming coaching cycle. Then in January, we do two different trainings, a training for coaches. Again, that's that training in our coaching protocol, and a training for our school professionals. That's that initial one-day training to orient them to our CBT and mindfulness approach. Then from January to June and September to December, and again, this is just the example of our Detroit-Wayne County initiative, there will be 2 rounds of coaching, and then we collect a lot of data, both about the students that are participating in groups, as well as implementation outcomes among our school professionals. Are they utilizing CBT and mindfulness? Are they serving students? And what are we seeing in terms of their sustainment of use of CBT long-term? I see a question has popped up. How much are these trainings generally offered for? I'm assuming that that means a price point. So it's very hard to offer a price point, in part because to date, all of our work has been grant funded. And so all of this work has been provided to the schools at no cost. I have with me our Trails program manager, and if there are specific questions about costs, we can certainly loop her into the conversation. But I would say that it's very dependent on the community. If we are offering a training for 60 to 100 coaches in training, that would be one cost. If it's a much smaller community where we're only training 15 or so coaches, we work in the Upper Peninsula of Michigan, where sometimes we do a training and there just aren't that many providers in that part of the state, so the training would be much smaller and more affordable. When we're offering trainings to schools, that is has typically been at no cost, although as our capacity to continue writing grants all night long wanes, I'm not sure that we'll be able to provide it at no cost forever, but we're doing our best right now. I hope that answers your question. I don't see another question.
Trails model been implemented with an outcome report in any community in Michigan?
So the question was, has Trails been delivered with an outcome report in any community in Michigan, or is Detroit and Wayne County our first pilot? So I'm actually going to get to that in a moment, so sit tight on that question. The short answer is we have lots of places where we've implemented the program locally, regionally, and statewide, and we have a number of outcome reports. I am going to get to some of that moving forward. So if I don't answer your question, please pop up again, and I will do my best to answer it more clearly. So I want to talk for a moment about this consultation phase in a little bit more detail. As I mentioned, this is one of the phases of training that our CITs go through, and I just want to highlight a little bit about the intensity of this training. in case there are partners on the line that are thinking they might like to work with their community mental health, or you are a representative from community mental health or a mental health agency, and you're interested in having or learning more about how your staff could be trained to become a coach or what's entailed in development of a coach network. So the consultation phase is quite rigorous. It's listed on that slide as 12 weeks. It actually typically takes closer to 15 weeks just due to missed appointments and needs to repeat some content. But as you can see, the coaches that are in training go through all of the sessions excuse me, that provide them with exposure to the content that they will ultimately be coaching a school professional to deliver. And that content is transdiagnostic in nature, so applies to kids with both depression and anxiety symptoms. So in order to become proficient, we ask our CITs to make sure that they practice delivering all of the content rather than just a subset of those skills to, say, a student that only has depression or only has anxiety. So the CITs will select a case from their active caseload. We provide materials to help them gain family or caregiver permission. We provide them with the session-by-session agendas and those supporting materials. And then we also give them tools to evaluate their skill and learning. And we give them tools to evaluate outcomes in the clients that they're serving during that consultation phase. When they complete consultation, again, they go back to that coach protocol training. That's that one-day training where we are not focused on the clinical content any longer. We're focused instead on how do you provide coaching to a school professional. Then, as I mentioned, they partner with their school professional during delivery of 9 to 12 weekly sessions. These are CBT and mindfulness skills groups. The school professional's role, as I said, is to be the primary group leader. So they make referrals of students, they schedule the room, they make sure students are attending, they are responsible for parent permission. Trails is certainly not interested in managing parent permission of the hundreds of kids across the state who are participating in school-delivered CBT and mindfulness skills groups. So the school professional is really in charge of all of those pieces, while the coach is really considered a secondary or maybe even a tertiary group leader. They do participate in the group, but really their role is to support that school professional, model skills, answer questions, observe fidelity, and then there's some paperwork that we ask them to fill out evaluating the fidelity or adherence of the school professional to the model and providing pointers to the school professional about what they could work on or where there are resources on our website to help them learn a little bit more. All right, I'm going to pause for a moment to look at some of these questions. Is Trails available to staff who do case management skills training in schools and homes, or only specifically with therapists? So we are really not particular about who we partner with in terms of their stated role. As I said, we're working primarily with staff in a school who do not have in their job descriptions that they're offering therapeutic services. So right out of the gate, we understand that what's in a job description may not align closely with what's actually happening. And then as to the question, I think this is the question about, can the coach be somebody who does case management or skills training rather than community mental health clinicians working directly with kids or families? Absolutely. Anyone can become a coach as long as they meet sort of two fundamental criteria. One is that they have an available caseload from which to pick a practice case to implement the Trails materials to during that consultation phase. And the other is that following their training, if they're selected as a coach, they will be able to partner with a local school. If they meet those two criteria, then we are happy to partner with them. And I will say that as we reach into deeply rural parts of Michigan, where there are open mental health positions that have not been filled in years at some of these mental health agencies, we really don't have the luxury of being terribly selective about who we're partnering with. We really just want to work with whoever is in a position to help. Great. All right, I'm going to move forward here. So there's a map of the current coach network. I have to say that we should now add a blow-up window of Wayne County, which would be in the bottom right-hand corner of the state, because as I said, we just did our one-day training with about 80 clinicians from that region. But this is our network of coaches across the state. And then somebody asked where we have implemented the program. Here's our network of schools that are participating in trails statewide. And that blow up on the left is Washtenaw County, where the University of Michigan is located, where we have additional funding to push out into all 40 middle and high schools in Washtenaw County. But you can see that trail schools are all over the state. This map comes from an internal document that we utilize that has some other information embedded into it. So that's why you see those different colors. And in fact, one of those colors has to do with randomization within an NIMH-funded R01 clinical trial, where we are looking at the relationship between delivery of the TRAILS program or implementation of the TRAILS program and primarily school professional outcomes, examining whether schools that are randomized to the full TRAILS model demonstrate adoption and utilization of CBT and mindfulness above and beyond rates that we see in schools that are randomized to a training-only condition. So that is one study where we are in the middle of data collection, but we have a number of other settings in which we are also collecting data and looking at outcomes both between school staff and students. So we have a number of current initiatives. That top one is one that I just mentioned. That's our NIMH study, where we're randomizing schools to TRAILS or a similar training control condition. We also have a U.S. Department of Education grant, a full-service community schools initiative that is looking at partnering with 4 high-poverty, high-density districts locally in Washtenaw County. We have an initiative with Detroit Public Schools funded by the Centers for Medicaid as well as some local Michigan foundations. We have a partnership with Detroit Wayne Mental Health Authority. That is the training that I just mentioned yesterday, and that is funding that's a contract through Detroit Wayne Mental Health Authority. We partner with our local school district, as you saw on the map. We have another R01 that we recently submitted, and we are in the process of submitting a randomized controlled trial proposal to the U.S. Department of Ed, to the IES division. So lots of initiatives. I'm going to mention some of these in a little bit more depth moving forward, but you can see that we keep ourselves busy here at TRAILS. So going back to that R01 study, here are the primary questions that we're looking to answer. Certainly we want to understand the climate. There's great evidence that the environment and climate within a building has a huge influence over both the mental health and wellness of students and also staff intention or ability to adopt and utilize evidence-based practices. Sorry, just taking a drink of water. We also are collecting a lot of data from our school partners, their professional staff that are working in the buildings. Our primary outcome, of course, is are they using CBT, but also what do they think about CBT? Do they find it to be appropriate and useful for their role in the school setting? Do they find it to be helpful? And their fluency, how well, how seamlessly can they use it? Can they adhere to our materials and model? And then among students, of course, this is an NIMH-funded study, so we look carefully at outcomes of students, both their clinical symptoms, manifestations of depression and anxiety, as well as their academic performance. Here's that U.S. Department of Education grant that I mentioned. This is a little bit of a different project. The full-service community school grant is really looking at embedding TRAILS within 3 tiers of service, and I'm going to talk about those tiers more. I'm sure many of you on the call are familiar with PBIS. And so this grant really enables us to situate trails within a Tier 1 model and a Tier 3 model. Tier 1 thinking about the whole school community, and Tier 3 thinking about specifically students at risk for suicide or significant self-harm or homicide, and ensuring that those kids that are identified as having a much more elevated level of risk are connected with services efficiently and appropriately. Here's our Washtenaw, local Washtenaw initiative that I mentioned. As I said, we have funding from another source that enables us to partner with our local schools. So over a 2-year period, we are partnering with the 40 middle and high schools in our local county. You can see that some of them partner and participate in more than one cohort. Some of these are large high schools, and they decide to send some staff to one cohort and then continue to partner with us so that they get more staff trained. I think in some of our biggest high schools, we may have between 6 and 10 staff participating over the course of this 2-year initiative. And then I also mentioned that we're working with Detroit. We have a new partnership. Well, now it's actually about a year old. It feels new because we're so excited to be working with Detroit Public Schools. This is a district that has over 100 buildings serving K-12 students, over 50,000 students, and approximately 4,000 staff and faculty. And as you can imagine, especially if you're from the Midwest and joining us relatively locally, you know Detroit is heavily impacted by environmental stress and trauma exposure among their entire student population. They have about a 97% minority rate, and rates of high-risk behaviors are much higher in Detroit compared to national averages. Kids engaging in substance abuse, kids with documented symptoms of depression and anxiety, kids with exposure to those ACEs that I mentioned in that very first slide. And Detroit has historically experienced really difficult, struggling academic outcomes. On any given day, they have about a 50% absentee rate, and about a fifth of students drop out of school prior to graduation. So in our Detroit-based work, we're really thinking also about embedding trails within that 3-tiered model to make sure that we are doing whatever we can to try to influence both the climate and the culture related to mental health in the district, as well as to move the needle on access to services and resulting clinical and academic outcomes. Here's a little bit of a deeper dive into what we're doing in Detroit Public Schools, and increasingly, as we partner with whole districts, we are focused more on this 3-tiered model, again, situating trails as a Tier 2 intervention, sandwiched between some prevention, stigma reduction, and sort of universal school programming at Tier 1, and suicide prevention and intervention coordination work at Tier 3. So Detroit recently adopted their Blueprint 2020 and their whole child commitment, highlighting student wellness as a key priority of the district, both for its own goal of improving student wellness, but of course also related to their efforts to improve academic engagement and achievement district-wide. At Tier 1, what this looks like is training in Michigan's new social-emotional learning competencies for all staff. So sitting with me here in the room is Lauren Kazee, who helped to draft all of the social-emotional learning competencies that have now been adopted by the Michigan Department of Education. We're fortunate to have her on our team half-time. So we provide training in those competencies, but then we've also looked closely at resources that are available to instructional staff to help them bring in those SEL competencies to their classrooms. And what we found is that a lot of what's out there, published curricula, lack a strong foundation in a theoretical approach, and specifically in a CBT approach. So we have spent the past 6 to 12 months developing a sister program to the Tier 2 CBT and mindfulness curriculum that I've been talking about so far. The sister program is designed specifically for the classroom setting and bridges those social-emotional learning competencies. You're probably most familiar with those thinking about CASEL and the work that CASEL has done to identify those 5 core areas. I think I have a slide upcoming that shows that graphic. So our work links those competencies with our core components of CBT and mindfulness and provides a set of curriculum materials that will enable a school classroom teacher to offer brief lessons to any classroom. So it could be a grade level in the elementaries, or it could be a subject matter class in the middle and high school classes. As well as that social-emotional learning piece for instructional staff, providing training and resources to support integration of SEL and CBT to the whole school environment. We also think about our family and community environment, making sure that we are reaching out to families to extend, again, that reach so that kids who are learning effective skills in the school setting are able to get reinforcement of those skills in the home environment. In our Detroit work, we work very closely with their family and community engagement team. They have a team of about 25 full-time staff whose primary role is to engage parents and families, deliver programming. They have a parent academy, they have a parent network, and we are close partners with them, thinking about what materials parents need access to, what supports they need, and how we can help them be better advocates for their kids. Tier 2, I think I've already talked about extensively, but of course, this is also occurring in our Detroit initiative. That's that typical support, training, and coaching for those student support staff. So I'm going to skip over Tier 2, given how much I've already talked about it today. Tier 3, we're really thinking about how to help Detroit Public Schools staff better identify students at risk of suicide or significant self-harm or injury, and how to make use of standardized assessment screening tools and communication tools, so referral protocols and sharing of information with local providers, both through community mental health and their emergency departments at local hospitals. So how do we make sure that those kids don't slip through the cracks? Detroit has one of the highest suicide rates of students in Michigan, and certainly an above average rate of suicide and suicide risk on a national level. I wanted to share with you today a brief video that was recently developed. I thought it would add a little bit of break from hearing my voice. So our hosts are kindly going to help share this video, and you can learn a little bit about our 3-tiered model.
Some people have a therapist that they go to regularly, but not everyone has that.
A lot of students suffer from anxiety and depression, and I think it needs to be more recognized that you aren't alone.
Oftentimes in our area, to make an appointment with a counselor could take months, and who's going to pick them up? How are they going to pay for it? They give up. There's just a lot of barriers.
We provide training for our school professionals. We offer resources and materials to support them in their work, and we link them with a Trails coach who can assist them in practicing and refining their skills that we've taught in our training.
This is a win-win from U of M. I thought, how can I not be a part of this to educate kids? Everything's laid out really clearly in the lessons. We focus on relaxation, educating them about anxiety and depression, coping skills.
We've learned how to recognize when you are having symptoms of depression and anxiety and how to combat that.
I was going through some problems with myself. I wasn't able to talk to my parents or my friends because I was scared, what are they gonna think? I've been able to open up and take care of myself more.
have someone that you know and you recognize that you can come up to and go, hey, I'm having difficulty with this. I feel like that's really important.
Students who are in the peer-to-peer group go to a couple of conferences a year. They learn about mental health and mental illness. They come back and they plan a campaign.
I think it's important that when you're struggling, you know that point when you're like, I need to go ask for help.
If you need the right support, we can find you a person to talk to.
It should be something that people try and help others with so that we can grow as a community.
The thing that makes it really credible is it's a U of M program, and the results show that it has increased awareness, it's reduced stigma, and it has increased help seeking when it's needed. What's really cool is they've created a manual available to anybody on how to do it.
I know it's helped me a lot, it's helped my friends a lot, and it's helped my family a lot. So to have other schools do that, it'd be really helpful for people who are going through it now.
So this is Elizabeth back. Again. Looks like we're getting a note on my end that video didn't complete, but I'm hoping maybe it completed on your end. She's saying it completed. If anybody else did not see the video through to the end, feel free to just type a note. So we are really fortunate that the University of Michigan offered to build that video for us to highlight our work, and you can see also highlighted in there was our colleagues program Peer-to-Peer, which provides some of that Tier 1 programming, and we really enjoy partnering with them because as you can imagine, reduction in stigma, increase in awareness, increase in help seeking only helps us engage more kids in this programming and gets more staff in the buildings on board with the goals and purposes of what we're trying to do. Okay, I also wanted to talk a little bit more in depth about these 3 tiers and how we are implementing these 3 tiers of programming that you saw partly highlighted in the video, but also in my prior slides within Detroit Public Schools Community District. So the first year was a needs assessment, and I would say that any time that we're thinking about partnering with a new school, a new district, a new region, we really want to think carefully about starting with a needs assessment, identifying priorities in the community, both from the perspective of students and staff and administrators in the buildings, but also from the community. And then in years 2, we provide a pilot of the programs that are informed by that year 1 needs assessment and data collection. And then in year 3, we offer full-scale implementation of programs based on feedback and data collected during the year 2 pilot. In Detroit, what this has looked like is a needs assessment. We are surveying a wide array of partners, teaching and school support staff, building principals and administrators, district leadership, as well as families and community stakeholders, including partners in our behavioral health care agencies. And that needs assessment feeds into some analysis work that we do, as well as development of a full comprehensive report looking at what are the needs identified from the community, what are programs that are already working well in the community, and of course that feeds into that second year piloting of programs. I want to talk a little bit about our partnership with Detroit Wayne Mental Health Authority, which I also mentioned briefly. Again, you saw that slide earlier that was highlighting the timeline of training their clinicians to become Trails coaches, and then partnering those coaches with school professionals through those 2 cycles of coaching. So Detroit Wayne Mental Health Authority oversees and is the lead organization that oversees all of the individual community mental health agencies throughout Wayne County, including Detroit. So they were able to put together a funding package for us, and you can see on the right side of the screen all the different agencies that are partnering with us through this initiative to develop their clinicians as Trails coaches. We are just beginning again that consultation phase, and then they will be pushing into schools starting in January to offer that coaching. Sounds like there's a couple of questions that have come up since the video. In particular, is Trails and peer-to-peer only for Michigan schools? So it certainly doesn't have to be. Due to the structure of our grant funding and just in particular due to the pace at which we have grown as an organization, Trails is currently only in Michigan, as is peer-to-peer, but we have had broad interest from the state of Massachusetts, from California, from Alaska, from a couple of other states, looking to pull the program into their districts as well. And of course, we're really excited to be on the line with so many of you today from across the Midwest region. Exactly how we would go about partnering with a new state, I think, would require some careful thought and attention and certainly collaboration with a new setting. There's some things that could certainly make a partnership like that go more smoothly, and one of the things that's been really appealing to us about this group in particular is the interconnected nature of the collaborative, that there are already connections between community mental health partners, school partners, and of course having the Technology Transfer Center as a lead partner to help make sure that communication and materials and protocols are shared collaboratively and in an efficient and really smooth manner. This is a really ideal opportunity for us to think about expansion to a new setting, so we'd be happy to talk with anybody following today's presentation who might be interested in thinking about that. I hope that answers that question. We are actually sitting today in the offices of the Youth Policy Lab at U of M, so we are co-writing our U.S. Department of Education grant with them right now, so I'm on a break from a 9-hour grant writing day today. The Youth Policy Lab focuses on program evaluation for the purpose of influencing public policy. So their expertise is in collection of large data sets and then analysis of that data to think about how can they recommend political changes and policies at local and state level that will have public benefit specifically for kids and families within Michigan. So we're really excited to be partnering with them, and they are helping us complete our program evaluation of our Trails initiative in Detroit and in Washtenaw County. The first step of that partnership was really developed through implementation of that needs assessment. As I mentioned, I'll go back a slide. In Wayne County, in our partnership with Detroit, we wanted to begin with this needs assessment, collecting data from a wide array of community stakeholders. So the Youth Policy Lab has helped us just recently complete a baseline evaluation and needs assessment in Detroit Public Schools. I shouldn't say complete, we're actually in the middle of it, but we completed the staff portion of it in the spring, and we had about a 98% survey response rate among school staff. As you can see, of those 4,000, approximately 4,000 staff in the district, we had 3,900 completed surveys, and those surveys were inquiring from school staff about their perceptions of student health and wellness in their buildings, where they have adequate resources and support, and where they really feel that additional training and programming would be beneficial. And then, of course, about things like their own wellness, burnout, perceptions of mental health, stigma, and their interest in ongoing or expanded professional development opportunities. So we are really excited about that data, and of course, now we are just beginning to go through that data and look at it more closely with the help of the Youth Policy Lab. Here's some of the comments from the staff that participated in that survey and some of the themes that emerged. Absolutely a request for more training, more resources, and more information about the relationship between mental illness and academic achievement. We heard from a lot of teachers that they just do not have the resources to help them serve their students, and that investment across all three tiers they really view as essential to being able to help improve student achievement. The next step of our needs assessment in Detroit is a student survey that's going to be going out this fall. We are very fortunate to have an outstanding team at the district who's supporting this work. They are helping us implement a survey to all students in grades 6 through 12, so that equates to approximately 25,000 students district-wide. And our survey is going to be giving them both a depression and anxiety screener, as well as embedded items related to their stigma, perceptions, and knowledge about mental health, utilization of adaptive coping skills, exposure to trauma and ACEs, and access and barriers to mental health care. So we'll be wrapping up that data collection at the end of October, and of course we're very eager to see what those students have to say. As we think about TRAILS moving forward, I just want to highlight these three primary initiatives that are underway. As I mentioned, TRAILS has grown very quickly, far more quickly than we were prepared for. Our first implementation of the program in 2 high schools in Ann Arbor was just in 2013. And as you saw from our maps and some of my comments today, we are all over the state and in our biggest school district statewide. And one of the things that has been a consistent request has been this K-8 expansion, that we began as a high school only model, but at every step, of course, we're aware that pushing down into the lower grades gives us the opportunity for earlier and earlier intervention. And so we are in the middle of building out our K-8 materials, which we hope to be available and plan to be available in January. It's a pretty extensive process to adapt our materials for the elementary level, in part because so much of that work entails graphic design and work with illustrators, so it's pretty slow. What begins as like a discussion or a handout with options for reaction for a high school audience, we have to translate into a story or a picture or an interactive activity in those lower grade levels. So it's just required a lot of time-consuming work from our design and technology team. I'm going to just talk once more about an initiative here, and then I do see that there's a question that I will make sure to get to. The other piece, as I mentioned, is this SEL, Social Emotional Learning curriculum. So this is that graph that's provided by Castle that I mentioned earlier, or graphic, I should say, that highlights those 5 social emotional learning competency areas: self-awareness, self-management, responsible decision-making, relationship skills, and social awareness. As schools are increasingly called upon to try to make sure that their staff are educating students in these social emotional learning competencies, we are really thinking about development of that curriculum that I mentioned. And so I have this as a future initiative. Actually, this is an initiative that's just about wrapped up. We have spent the past several months partnering with a group of 20 instructional staff from schools in Michigan to help us develop 20 brief lesson plans for each of 4 grade bands, so a K through 2, a 3 through 5, a 6 through 8, and a 9 through 12. Each of those has their own set of 20 lesson plans that bridges social emotional learning and our CBT and mindfulness framework, and will help us really expand that Tier 1 aspect of our program. And then our final initiative has been development of a web-assisted CBT skills group. So as I mentioned, there's a lot of schools that we partner with that just do not have social workers and counselors. The positions are open, or they have reduced their funding such that they only have a really part-time staff member who's not able to lead that work. So we are in the process of designing a tool that would allow a paraprofessional or another staff person in the building who does not have extensive clinical training or who is not positioned to offer mental health services to students to go to the website, open up the program, and support students to follow along using a workbook at their seat. The web-assisted model would have, again, interactive activities, would cover all the same content as our skills groups that are designed to be led by a social worker or counselor in the school, but it would replace the need for that more skilled professional in the building. This is something that I think is a little further out just due to competing demands on our tech team right now and our website, but certainly something that we're looking to complete within the next year or so. I do see that there's a question, how does the TRAILS model link to the Michigan model for health curriculum? So we use the Michigan model to help inform our curriculum development so that we're complementing what's advocated in the Michigan model. We also know that the Michigan model can be pretty expansive and covers a lot of aspects of health. And so we really want to make sure that what we're providing to schools is succinct and really highly focused on mental health and wellness and is low burden to teachers. In addition, the Michigan model is really designed for health class only. And while many students may rotate through a health class, we find it's really important as an environmental impact to have all staff speaking the same language and really on board with understanding a whole school approach to supporting student wellness. So while there's a relationship to the Michigan model, the TRAILS SEL curriculum is going to be much more broad and universal in its application. Okay, I see two other questions. Do I plan to bring these trainings to Pontiac? So I think that's a question maybe to follow up offline about. We are in so many communities, I think over about 75% of counties in Michigan are now implementing the model. So I would ask that person who's offering that question to follow up with me personally offline, and then we can talk about schools within that community that are already participating. Michigan also recently passed some state legislative funding to support school-based mental health programming and professional development for staff. And TRAILS was a recommended program through that legislative initiative, which is called 31N. So that's another way in which state funding can enable TRAILS to come to a local district. And then another question, do cohorts provide their own funding? So as I mentioned, to date, we have been all grant funded, but as our program evolves, we are really seeking to develop models to identify funding sources that districts have, either using title funding, state legislative funding, service contracts that they can utilize to bring the program into their district. We never want to block any school district from being able to access the program, but we also have to make sure that we're balancing our capacity to get our own funding to implement the program. I have one last slide here just inviting questions. I know there have been some, but I want to give people time to digest some of what I've talked about. I'm certainly happy to go back to any slide if somebody would like me to go backwards and revisit a slide or talk about anything else. Looks like we have some people typing questions, so I'm just going to keep waiting for a moment to let those questions come in. All right, I see a question. We provide mental health services mostly to Spanish speakers. Are any of your materials available in Spanish? I love this question because when we work in Wayne County and Detroit, we are actually translating all of our materials into 6 different languages, Arabic, Spanish, Hmong, Bengalese, like a whole bunch of, or Bengali I should say, a whole bunch of different languages. And so absolutely we are looking to get all of our materials translated. For the moment, our materials that are translated are primarily our survey measures and other data collection instruments. But for sure, by January, we are going to be deeply immersed in translating all of our materials because the population that we serve in Detroit is going to be extremely multilingual. I see a couple of other questions coming in, so I'm just going to stay on here. So just waiting for that last question to come in, so happy to be patient on the line here. I may have missed it. When was Trails Initiative started? So we had an early pilot grant in 2012 and 13, and that was just in 2 local Ann Arbor schools, and that led to very rapid growth. We then moved to a model within a couple of years of that that was utilizing regional community mental health providers as our coaches. And then in the last 2 years, we've moved to be a statewide model in those 65 or so counties across Michigan. And then also those deep dives within Washtenaw County and Wayne County. So it's been a rapid trajectory. So I don't want to needlessly keep people on the line. I think that my last slide here is my contact information as well as the name of our website. I don't know if that's a hyperlink on your end, but feel free to get in touch via email. There's also a Contact Us page on our website. And I will say, too, that we are just in the midst of finishing up a new version of our website. So if you check our website today and you check back in the next couple of weeks, you will probably see a brand new site on your screen. I did see one more person, I thought, typing a question, but I don't see that now.
Well, Elizabeth, I really appreciate your time and all of this fantastic information. People will be able to view the webinar on our website. It should be up in a couple of weeks. You can see our website on the slide. And we really encourage people, too, to sign up for our newsletter so you get more information about things that are happening and programs that we want to highlight. So I really appreciate everyone's time. Have a fantastic afternoon. And again, the slide, you can get to all of your state nodes if you have any questions about how to get information from us. And we will tell everyone good afternoon. Thank you
so much.